So now we're discussing regarding ideal sequencing or evolving strategy in RCC. That's the first line. So there is quite an evolution in the RCC from the cytokine era to TK era to immunotherapy era, later the combination era. So the combination is not just IO. The recent onset blockbuster combination is TK plus IO. Today we are going to discuss regarding the outcomes. So the treatment of RCC at the very beginning started with the famous interleukin-2 trial, and we understood it's a very immunogenic tumor and will respond very well to interleukins. Later, for the VEGF inhibition, the patients used to get treated with the sorafenib, later sunitinib, and later everolimus, pazopanib. We have seen the evolution of quite a few TKS. Now the recent lenvatinib, cabozantinib, and axitinib, we know how efficient they are, and they are multi-kinase inhibitors rather. So IO combinations as first line. If you see this, the treatment just got evolved from the TK to TK, and later to IO plus IO, and later to it is IO plus TK. So when I was a student, IO plus TK was just talked about, and it's always about PFS, but not about the OS was there. Now the OS data are also very mature, and now we are going to talk about entire spectrum of combinations. So IO is combination, IO plus IO, ipilimumab plus nivolumab. This combination was very famous in the inception, and it's very famous and very talked about for the CRs it provided, like 8 CRs was there in the Checkmate 214 trial. So at the inception, the IO plus IO was a very good combination and suggested to many people, but the toxicities are far apart. So later came the combination of IO plus TK with a different mechanism of action. So we all know pembro axitinib, many of us using axitinib plus pembrolizumab quite a bit, and later nivolumab cabozantinib and pembrolizumab lenvatinib and everolimus axitinib. So if you look at the Checkmate 214 trial, it's a phase 3 trial of nivolumab plus ipilimumab versus sunitinib in treatment naive RCC. So at the beginning, we used to few years before the risk stratification, good risk, poor risk, intermediate risk likewise. So good risk and intermediate risk, we used to offer sunitinib. And later, like the poor risk column, we used to offer IO, and it got changed drastically. This is the Checkmate 214. The intention to treat population, risk population, even the favorable risk population, this was the right side graph was talked about. So in the favorable risk population, the sunitinib versus IO combination, not much difference was there. Only little bit difference is there. So in the favorable risk, we used to offer sunitinib, and if an unfavorable, we used to offer combination of IO plus IO. So the 48 months PFS was seen, and later the ITT IP favorable risk for population was seen. Not much difference is there, but the PFS was like less with the nivo plus EP compared to the sunitinib. So this was a pointed out thing that the sunitinib worked better in a favorable risk population than the IO plus IO. And I'll again discuss regarding the Checkmate 214 CRs and everything later in the other slide. So next one is Keynote 426 pembrolizumab plus axitinib. There's an update analysis. The overall response rate was 60.4% versus 39.6. Again, it is pembro plus axitinib was compared with the sunitinib. One discussion was why not pembro plus axitinib versus axitinib. This was the discussion then, why not axitinib, why the combination was tested against sunitinib again. But the reason explanation was given was the sunitinib was then standard. But across the follow-up, you see a drastic difference between the combination of IO plus TK, that's pembro plus axitinib versus sunitinib. The responses rate were quite high. The CR rates were also quite high. 10% versus 3.5 is almost triple. CRs got noted. The longest follow-up of checkpoint inhibitor combined with the VEGF and VEGFR inhibitor of a first-line clear cell RCC is the Keynote 426. If you see the hazard ratio and the p-value is 0.001, which is seen in very few trials. So later, the Checkmate 9ER, that's nivolumab plus cabozantinib combination. Again, it was tested against sunitinib, but not cabozantinib. So these two trials, Keynote 426 as well as this thing, tested against sunitinib, which was the standard in good risk population and unaffordable poor risk population. Again, if you see, the cabozantinib plus nivolumab scored very well across the follow-up. So this is the one, be it a favorable risk, be it an intermediate risk, be it a poor risk, everywhere the combination worked very well. There was a consistent outcomes in internship population. Efficacy benefits with nivo plus cabozantinib was observed regardless of the IMDC risk status, organ site of metastasis, or extent of tumor burden at baseline. If you see, be it a liver disease, be it a bone disease, be it a lung disease, the combination people, they did really well. Almost like double and triple responses were noted. The oral response was double and triple. So cabozantinib versus this combination versus cabozantinib, I'm really interested to see. So it would be better trial than the combination against the sunitinib. And next comes the clear trial, and this is a very good trial. If you see, 3 arms are there: lenvatinib plus pembrolizumab against len plus everolimus and against sunitinib. If you see, lenvatinib plus pembrolizumab consistently did across the follow. It's almost, compared to sunitinib, it's almost 3 times benefit got noted in the PFS. And len plus everolimus scored better than the sunitinib. The overall survival, if you again see sunitinib, there is a flattening of the curve is there, and len plus everolimus is down the lane. It's the curve got flattened down the lane, but the sunitinib, the patients whoever did well on that, they did well. And len plus pembro down the lane got the curve got dipped. The survival property got dipped. If you compare the 4 regimes, that's a checkmate 214, keynote 426, 426, checkmate 9ER, and clear. The CRs were quite high in clear trial. That is 16% was noted. And the nivolumab, EP plus nivolumab, checkmate 214, the most talked about was the CRs at the time. That's 11. And the response was consistent, and it was like maintained with a long follow-up in checkmate 214. Maybe clear data if we follow later, we'll see what are the exact results. So checkmate 214, keynote 426, 9ER, and clear cell, they're comparable as per the prior nephrectomies. It's almost like equal. It is almost equal except the checkmate 9ER, and the overall response rates and everything is like drastically different. If you see ORR, checkmate 214, it is 39. For the same reason, they used to say when the burden of disease is very high, no, IO plus IO is not preferred, but TK plus IO is preferred, or TK alone is also preferred. So when burden of disease is very high, definitely TK plus immunotherapy, but not immunotherapy alone, because we want a significant responses like very fast. If you see the responses here, it's 60%, 56%, 71%. If you see here, 39, there's a stark dip is there. But PFS and all, the patients who got followed, who got responded, they got a decent response after a follow. But the numbers and figures are good in the clear trial. Len plus pembrolizumab, the numbers are good. Be it a OS, be it a PFS, be it a oral response, CRs, everything, like the numbers are really good in clear trial. So how to choose the first line therapy? IO plus TK, IO. So what are the pros of using combination of TK plus IO? Generally consistent effect across all IMDC groups. Initially I have shown checkmate 214. Sunitinib, it has scored well in the favorable risk, but not in the poor risk. So if you use the IO plus IO in the favorable risk, you're not going to get a good benefit. But if you see the response of TK plus immunotherapy, the response is consistent across all the groups. When the significant tumor burden is there, the reduction will be reflected in the high oral response rate and long PFS. The toxicities, as it was like mentioned, it is pretty much manageable. It's not so toxic.
My apologies, ma'am. You are left with 1 minute to conclude.
Sure. I'll wind up.
Thank you.
So durability of response is like we should have a long-term follow-up data to see it. And the IO plus IO, the CRs are very high. The durability of response is very high. So there is a data published from the Manipal Hospital, Bangalore. So they published their real-world data. If you see the total patients with lenvatinib and axitinib was used with the combination of pembrolizumab. The responses were quite high. The median PFS is 22 and OS at 1 is 92%. And the OS is yet to reach. This was present in recent ASCO. So the revised guidelines, if you see, be it the favorable risk, be it a poor or intermediate risk, the combination is highly suggested. The era of only sunitinib or only single TK has gone, and everyone is favoring the combination rather using the TK. So whenever a patient is affordable, then we can offer sunitinib or cabozantinib. Also, cabozantinib trial is there. So in that patients, we can offer that one. I thank you for the patient hearing. I'm happy to take any questions.